This is group 3 for kidney cancer, and we had Avelumab for our immunotherapy, and it's also known as Bavencio, and it's an injection. So the biology behind kidney cancer, we have our cell types, we have our tissue types, and we have our tumor types and our subtypes. So most of these are about the same. We have renal cell carcinoma, we have your urothelial carcinoma, we have Wilms tumor, which is nephroblastoma, and we have renal sarcoma and oncocytoma. Hopefully I said that correctly. These are, of course, big words, and a lot of these originate to the renal area, the nephrons, the tissues connecting certain cells, collecting ducts of the kidneys. It's just a lot of parts of the kidneys and the parts that work for the kidneys. And a lot of these correlate to the tissue types, the tumor types, and the subtypes. So as you can see that the cell type of origin also are about the same for tissue types and tumor types. For the subtypes, though, we have clear cell, we have papillary, we have chromophobe, we have collecting duct sarcomas, we have medullary sarcomas, and then we have translocation. RCC stands for renal cell carcinoma, which we see in the purple box. So a lot of these just are about the same. They're just different types, and they just originate in different places, but they all involve the kidneys and parts of the kidneys. So for the molecular consequences of mutated TSG, so TSGs play a critical role in the development of kidney cancer, and we have increased angiogenesis, we have altered metabolism, we have genomic instability, and we have transcriptional dysregulation, and we have resisting apoptosis. Apologies again. So with TSGs, obviously they play a critical role in the development of kidney cancer, and these are just these are just like roles that they play and things that they do. So we have mutations leading to HIF stabilizations. We have enhanced glycolysis and glucose uptake. We have resulting from defective chromatin remodeling, loss of histone modifications, reduced programmed cell death from BAP1 mutations. All of these effects compromise genomic integrity and regular cellular function while encouraging cell survival and invasion, which aids kidney cancer. So it's mostly the mutated TSG. When there's mutations involved, it helps the kidney survive. It helps the tumor survive and live in this certain area. This can play a role in any kind of cancer, but in kidney cancer, this is what exactly it does. So for our immunotherapy, we have some of its purposes, the things that it does, that how it affects the cells and how it affects the tumor cells. It's actually a checkpoint inhibitor. It's used to treat various types of cancers. So some of those cancers were mentioned earlier in the earlier slides. So it's just like different parts of different types of kidney cancer. It targets PD-L1 and the PD-1 pathway, which is critical. It's a critical mechanism for immune evasion in cancer. It blocks the PD-L1 and then restores T cell activation and enhances anti-tumor immune response. It's also mentioned before, a pathway for PD-1 is upregulated in cancers through oncogenic mutations and inflammatory signals, making it a pivotal target for cancer immunotherapy. And it also inhibits the tumor's ability to escape the immune system and enhances immune response against tumors. So we have a picture over here. This is actually from the website that explains exactly what this immunotherapy does and how it goes in and works with the tumor cells. And yeah.
Hi, my name is Samantha, and I'm going to be talking about the public health problem of kidney cancer and an observational study of smoking as a risk factor. So all my statistics and graphs are from the CDC, and they are for kidney cancer and renal pelvis cancer. According to the CDC, it's the ninth top cancer in the US by incidence, with 17 new cases per 100,000 and a mortality rate of 3 per 100,000. And there are variations in who gets this cancer. It's more common in men, and it gets more common with older age. So these graphs depict the incidence and mortality. Incidence is here on the left, mortality is on the right, and on the top is the number of new cancers or the number of cancer deaths, and on the bottom is the rate. And as you can see, incidence has been increasing, but mortality has been decreasing over the past 20 years. And these graphs are showing the same information, 1999 on the top and 2021 and 2022 on the bottom. Shows an increase in incidence, but a decrease in mortality. And these graphs also show you a breakdown based on states and which states have higher risk. This graph shows you the risk of, or the rate of kidney cancer based on sex. It's more common in males versus females, with a rate of 23.3 versus 12 per 100,000. And this is based on race and ethnicity. And as you can see, the highest rates are among Native American and Alaskan populations, and the lowest rates are among Alaskan and Pacific Islander, or Asian and Pacific Islander populations. This graph shows the rate based on age. And as you can see, as age increases, the rate of cancer also increases, with the highest rate seen between 75 to 79 years old. And this graph throws these two together, and it shows the difference between sex and race and ethnicity. And it just shows the same trends that are seen up here. So for my study, I chose cigarette smoking and other risk factors for kidney cancer death in a Japanese population. And this study recruited 46,000 men and 64,000 women ages 40 to 79 from the general population and from routine medical checks. The cohort was established from 1988 to 1999, and upon joining, people were given a survey to determine their levels of smoking. Smoking was broken down into 3 categories, which was smoking status, which is never, former, or current smoker; smoking index, which is calculated based on the number of cigarettes per day times the years smoked, and the duration of smoking. Follow-up was done until 2009 and they were looking for the outcome of death due to kidney cancer. And as you can see, the hazard ratio for smoking indicated that there was an increased risk for smoking compared to non-smokers, regardless of level of smoking. But the only significant finding was for people with a very high smoking index score, so a heavy smoker, and they had a hazard ratio of 2.95. So as I said, the study found an increased risk for heavy smokers, and it indicated that it's a moderate risk factor for kidney cancer, especially as you increase your smoking. Some issues with this study was that your smoking status was based on self-reporting. So people could introduce bias by over-reporting their smoking habits, and follow-up was done to determine cause of mortality, but it was not done to see a difference in smoking habits, which could skew the results. Overall, the study showed that preventing smoking can help to prevent kidney cancer.
All right, how's it going? My name is TJ Jakimas, and I'll be discussing the efficacy of Avelumab along with the risks and benefits of this intervention. So just to start off, Avelumab is an anti-neoplastic, which means that it is used to change the immune system to help control the growth of cancer cells. To begin with application of this intervention, Avelumab is usually given via an IV drip at a dose of 800 milligrams for 60 minutes every 14 days or 2 weeks. This long rest period is what allows the patient's body to rest and recover before the next cycle takes place. Avelumab is also used to inhibit a protein called PD-L1, which, when combined with PD-1, prevents T cells from killing cancer cells, which then therefore allows the cancer to proliferate and grow. And by inhibiting this protein, it would no longer be able to bind to PD-1, allowing the T cells to attack the cancer cells and kind of stop the spread, which is obviously what you want with an intervention. Avelumab is also used as a first-line treatment for kidney cancer. However, it can also be used as a second-line treatment for other cancers such as urinary tract cancer. And basically what this means is that patients who receive other medicines that did not work would get Avelumab as a secondary treatment to try and alleviate the problems. Additionally, it is also combined with azidanib, which is a targeted cancer drug, which inhibits vascular endothelial growth factor receptors, or VEGFRs. All right, so a little about the efficacy of avelumab. A phase 3 randomized trial was run to test the combination of avelumab along with azidanib against sunitinib. So basically what a phase 3 trial is that it was used to test a new medicine against the standard practice, which in this case was sunitinib. And based on the results of this trial, the combination of drugs were shown to improve PFS, or otherwise known as progression-free survival. PFS is the amount of time a patient lives with the disease where it does not get worse. All right, so a little bit about the risks and side effects. It has the common side effects of most cancers, which include things like hair loss, fever, joint pain, things of that nature. However, some rare side effects of this intervention include difficulty or inability to speak, along with trouble sleeping, and patients may not have the ability to move their arms or legs either. But then again, these are the rare side effects, so patients should not be as concerned about these when taking this drug. And lastly, is some of the benefits of avelumab. It was the first FDA-approved drug for treating MCC, or Merkel cell carcinoma. It was also the first human anti-programmed cell death ligand 1 antibody. It also has various uses, as it can be first-line or second-line treatment.
Kidney cancer primarily includes renal cell carcinoma, which accounts for about 90% of cases. And RCC has several different types, including clear cell RCC, which is the most common and the most aggressive subtype. But other subtypes include papillary RCC, chromophobe RCC, and many others. And the prognosis varies based on the stage at diagnosis. So early stage kidney cancer has a better prognosis with a higher 5-year survival rate, whereas in advanced stage kidney cancer, it does have a poorer prognosis. And the 5-year survival rate for localized kidney cancer is around 93%, whereas for metastatic kidney cancer, it drops to around 12%. And kidney cancer often spreads to the lungs, bones, liver, and brain. And metastasis is common in the advanced stages, which leads to a more challenging treatment plan. Avelumab is an immune checkpoint inhibitor, and it is used in combination with other drugs, such as this tyrosine kinase inhibitor. And this combination has shown improved efficiency compared to the monotherapy, and the combination works particularly well for advanced or metastatic RCC. And the treatment protocol typically involves the administration of avelumab intravenously every 2 weeks. And the overall patient experience can vary. Some people experience significant benefit with this drug, and they have manageable side effects. Others, their quality of life have been impacted, and they have more severe side effects. And the resistance to this drug can develop, and leading to the need for alternative treatments. Patients with certain biomarkers, such as the PD-L1 expression, they may experience better outcomes with avelumab. And it's factors like patient's overall health, the presence of certain genetic mutations, the extent of the disease that patient has, that can all influence the effectiveness of the treatment. Avelumab targets the PDL protein and is expressed on the surface of the cancer cells. And the protein binds to the receptors on the T cells and inhibits their activity, and it allows the cancer cells to invade the immune system. And this blockade enhances the immune system's response against the cancer cells by preventing that off signal, and it helps promote the T cell mediated killing of the cancer cells. And avelumab is designed to specifically target the PD-L1 expression, which makes it a relatively specific therapy. However, because PD-L1 can be expressed on normal cells, not just cancer cells, there can be off-target effects. And these effects are due to the immune activation against the normal tissues that are expressing the PD-L1 protein. And this can lead to autoimmune-like symptoms, including thyroiditis, hepatitis, and many others. The therapeutic index of avelumab is considered favorable, with a significant portion of patients getting benefits from the drug. However, there are side effects, and it is important to manage them and maintaining the good balance. The development of avelumab was based on the understanding of immune checkpoints and their role in the cancer immune invasion. And by blocking the PD-L1, avelumab helps restore the immune system's ability to recognize and attack cancer cells. This rational development was supported by preclinical studies demonstrating the efficiency of the PD-L1 blockade in enhancing the anti-tumor immunity. The development of avelumab involved extensive clinical trials to evaluate its safety and efficiency. These trials have shown that avelumab, especially in combination with other drugs, can significantly improve outcomes of patients with advanced or metastatic RCC. Overall, avelumab represents a significant advancement in the treatment of kidney cancer, particularly for those with advanced disease, by leveraging the body's immune system to target cancer cells more effectively.